So why don't we get started? Hi, everyone. I'm Salmia Mayapin. I'm the manager of the Learning Health System here in academics at Women's College Hospital, and very happy to welcome you all. If it's your first LHS seminar, we're especially glad you're here, but we're really excited about this seminar, especially as we welcome 3 internal initiatives. So if we move on to the next slide, just wanted to give everyone a quick overview about the LHS seminar series in general. So as many of you may know, Women's is on the journey to becoming a learning health system. So what that means is this is a model, it's a framework where we'll foster a culture of curiosity and engagement to really see, are we adding value? Are we being reflective and thoughtful? And how can we work together to effect improvements? The seminar series actually launched just about 6 months ago in September. It's a monthly virtual series that in general, or usually we feature external speakers to share their experiences with developing a learning health system at their respective organizations. And the reason behind this is to really inspire some ideas to those who are in attendance on what this kind of a model could look like at Women's, and for us to really think about what are the different components that we need to consider as we start developing and executing on this vision. And we've opened up these series to everyone at Women's, so all staff, trainees, and physicians. And it's really part of our wider learning health system or LHS communication strategy. So we really want to, disseminate all, information about our vision, about what we plan to do. And the seminar series is a good way to kind of piece together our vision with some other ideas. And so just to give you a recap on what we've done so far with the seminar series, as you may recall, we've had 4 sessions so far, largely from external speakers. And as you know, for today, we're featuring 3 internal initiatives, and we're calling these learning moments at Women's College. I will be introducing each of the speakers shortly, but you can kind of get a quick sense of the next 4 months and kind of what we have slated for presentations. And so specific to this talk, we thought it would be great now that if you've been able to attend at least 1 or 2 of the previous seminars, it's great to learn about other organizations, but we thought let's take the time to showcase some internal initiatives that closely resemble or align with components of a learning health system model. So on the right, we have that diagram that many of you may have seen some iteration of this. It's really that cycle of bringing practice or performance to data, taking that data, analyzing it, converting that to some kind of knowledge, and then bringing that knowledge back to practice. And so we had chose these 3 presentations as we think that they're great examples of how, their initiatives kind of align maybe with one part of the cycle, maybe with 2, or maybe with all 3 components of the cycle. So take what you've learned so far, whether it's from what Rulan has said about learning health systems, or maybe from previous LHS seminars, or other information that we've shared, and combine it with what you're about to learn in these seminars. So hopefully there will be some familiarity. Some of you might already know about these initiatives, and it might help make those connections a little bit more to demonstrate that, yes, Women's is on the journey to becoming a learning health system, but we're already doing quite a bit of the work already. So without further ado, I'm happy to introduce our very first speaker, and this is Sue McRae. Sue's a registered nurse and registered psychotherapist. She has expertise in both group and individual therapy modalities. She's also a certified internal family systems therapist and has additional specialized training in other childhood trauma treatment modalities, such as mindfulness-based stress reduction, sensory motor psychotherapy, and neurofeedback. So Sue currently works full-time at Women's in the trauma therapy program. So welcome, Sue.
Thank you so much, Soumya, for your kind introduction. It's truly an honor to be here representing the Trauma-Informed Care Research Team for this exciting session in the Learning Health System lecture series. So according to the Agency for Healthcare Research and Quality in the US, they define a learning health system as a health system in which internal data and experiences are systemically integrated with external evidence, and that knowledge is put into practice. As a result, patients get higher quality, safer, more efficient care, and healthcare delivery organizations become better places to work. So I'm excited to present on the topic of transforming healthcare through asynchronous trauma-informed care, or what I'll call TIC education, which our team believes is a wonderful example of a learning health systems approach. So on this slide, I'd like to begin my talk before I kind of get to what's on this slide, sharing a bit of context to this important topic of trauma-informed care. So the research shows that in our society, we have staggering numbers of individuals who have suffered from trauma from child abuse, domestic violence, sexual assault, from war, poverty, and relocation, just to name a few examples. For childhood trauma alone, the statistics show rates of approximately 60% of children in Canada who say they have experienced some form of abuse before the age of 15, including emotional abuse, neglect, physical abuse, witnessing violence, and sexual abuse. And what we know about psychological trauma is not only about the events that happen to people, but the lingering impact in the way trauma sets people up in their nervous systems, their bodies, and brains to re-experience symptoms such as emotional dysregulation, hypervigilance, trauma re-experiencing of triggers, high states of anxiety and stress, just to name a few. And these show up long after the events are over. So evidence from research shows that trauma survivors are not only high utilizers of healthcare systems, but they often report having their needs unmet by the healthcare system. And when we think about the extent of this problem of psychological trauma in healthcare, we need to think not only about our patients, but also healthcare professionals, as they are also members of the general society and so are prone to similar rates of trauma, as well as being further exposed vicariously through work with patients, not to mention other work-related traumatic stressors and contexts like the pandemic. So with these high rates of trauma, you'd hope that our healthcare system would be well equipped to help address the needs of trauma survivors and the healthcare staff that care for them. But in fact, however, there is an increase in some trauma-informed education strategies out there, but there's a significant gap in the lack of accessible, affordable, scalable training for healthcare staff on trauma-informed care. And it's this gap that our project seeks to fill with an asynchronous trauma-informed care learning course. Overall, our team is working towards a vision where Women's College Hospital can be an incubator for what we believe to be cutting-edge, patient and staff-informed trauma education offered in an innovative, asynchronous format, which we hope can be scaled and spread more broadly across the healthcare sector. And quite frankly, knowing the prevalence of trauma and its impact to our patients and healthcare colleagues in our hospital, we believe it would be negligent not to offer this solution. So I'll describe in this short presentation 2 phases of this project. Phase 1, which has been completed already, involved a needs assessment around curriculum development, and phase 2, which is currently underway, that involves the creation of the virtual asynchronous course on trauma-informed care. So first, some information about phase 1. This phase included a needs assessment, which sought to understand needs and potential barriers to implementing a virtual asynchronous TIC curriculum. And you'll note I'm going to use TIC for shorthand for trauma-informed care through the rest of this presentation, just to save time. The funding for this phase 1 came from the University of Toronto Department of Psychiatry Excellence Fund. In phase 1, an anonymous survey was done with healthcare professionals from nursing, psychiatry, social work, and occupational therapy, seeking their input on their needs and preferences for a curriculum on trauma-informed care. You can see the percentages here. The other key part of the data collection in phase 1 was a series of semi-structured interviews with patients, healthcare providers, and healthcare leaders and experts. The engagement of patients into this project was a priority, and we believe that it's one of the things that sets us apart from other TIC curriculum development. By the end of phase one, much feedback was gleaned about perspectives on the asynchronous TIC course, which allowed for a curriculum outline to be created. So I present here just a few findings from phase one. On this slide, you'll see the results from the perspective of clinicians on the question of how relevant or important is trauma-informed care to your role or area of practice. So what we see here is 81% approximately said very important and 15% said somewhat important, which puts that up to about 96.2% that said that trauma-informed care was very important or somewhat important in their role or area of practice. Notice here that 0 individuals said that TIC relevancy in their role was either unimportant or somewhat unimportant. On this slide, you can see to the question of level of interest in taking a virtual course in trauma-informed care, and this was regardless of whether they had had previous training. 95.3% would engage with the TIC course if it were offered in a virtual format, which we found to be quite promising. So in phase one, there were a number of topics. We weren't sure like what we should be covering in a curriculum like this, which is exactly why we did this engagement. And we explored with participants a number of different options for course content. So some of the options we explored were neurobiology of trauma, related symptoms and responses, the knowledge of trauma itself, like a definition, prevalence, impact, and recognition, understanding that common mental health symptoms can be understood as trauma coping strategies, how trauma diagnoses and symptoms can overlap with other mental health diagnoses, using trauma screening tools, managing disclosures, using coping skills like grounding and emotional regulation strategy with patients. So you can see we were really trying to cover a wide range of things this curriculum could cover. The top 3 topics that staff and patients identified that were the priorities in the TIC course were how to ask about trauma and respond to patient disclosures to reduce the potential for re-traumatizing when delivering services, how to incorporate principles of equity, diversity, inclusion, and belonging into trauma-informed care practices, including performing cultural sensitive assessments, and trauma-informed care skills and strategies for general use in day-to-day work. Here are also just a few highlights of some key findings from phase one that have implications to support the development of our curriculum in phase two. The first point here supports the idea that busy healthcare professionals would be interested in taking a virtual self-paced course on trauma-informed care. This was not a surprising finding for us, since we've found in other research in the trauma therapy program that patients have appreciated this format as well. So this was a supportive finding to know that this would be a useful format for staff as well. The second point speaks to the idea that healthcare professionals indicated the need to build confidence around speaking about and identifying trauma, specifically needing more tools to identify trauma and trauma symptoms. This point is related to another common theme in the research that healthcare professionals reported carrying a fear of re-traumatizing clients, which incidentally was also confirmed by patients who admitted that re-traumatizing experiences have happened to them in non-trauma-informed healthcare settings. The third point here on this slide speaks to healthcare professionals wanting specific practical tools to assist in the application of knowledge when practicing after identifying that trauma is showing up for an individual. So I've only presented a few of the findings from the interesting work from phase one, given the time, but I hope you can see that this first phase validates the importance and relevance of a project like this to support training of healthcare professionals on TIC and the natural likely extension of this approach to improving patient healthcare and well-being. So we'll just look at phase 2. The data collection from phase 1 leads nicely into this phase 2, which we're just starting now. And this looks more closely at building the practical application of developing actual TIC curriculum and testing it. Our team is very grateful for the funding from the WCH Breakthrough Challenge to help support the development and evaluation of a TIC virtual asynchronous course for healthcare staff. So our REB submission is ready to go for the end of the month. And then in phase 2, we're going to be building this multimedia curriculum. Along the way, use a continuous learning approach, seeking input from patients again, and healthcare staff. So this time, not only patient-facing healthcare professionals, but also non-patient facing, like, volunteers, secretaries, security. And again, we'll continue to interview other healthcare leaders and trauma experts as well. And the vision here for us would be that a patient walks in the front door of Women's College Hospital, and every person they would encounter would understand trauma-informed care. The security personnel, the secretaries, the volunteers, the students, the clinicians, and the MDs, all would have this TIC training to support themselves and individuals who seek care at WCH. Once the curriculum is built, there will be a pilot launch where the course will be further evaluated with pre and post questionnaires and focus groups. So lastly, a future phase 3 could evaluate the implementation of the virtual TIC course for healthcare staff at Women's College Hospital and beyond. We could imagine additional modules being built and tested in the future that are specific to needs of particular groups, healthcare staff, patients, or community needs, for example, trauma survivors with chronic pain or refugee patients. And we've noticed that building this course in a modular format allows for continuous testing and allowing for an iterative improvement rather than sort of a one and done large course. So of course, for us here as this Learning Health System series, some of the summary key learnings we've had is that our needs assessment confirmed the gap and a potential solution to the lack of TIC training in healthcare. We are seeing the value of involving patients throughout every phase of the design and development of the intervention. And a big issue that was identified during our needs assessment is that the educational initiatives in healthcare in TIC must focus on translating knowledge to practice, which of course we know is a key learning health system principle. So in this sort of last slide here of content, you can see how our project can map onto the learning health system map more specifically to our problem of interest, the need for accessible, affordable, scalable training. Our phase 1 data collection period nicely maps onto practice to data flow element of the model. Also in phase 1, we engage in the data to knowledge flow element with the creation of the curriculum map or outline, which is the result of much analysis and interpretation of the survey and interview data. In phase 2, we will apply the learnings from phase 1 as a knowledge to practice flow opportunity. The team will represent the knowledge manage, the knowledge application in the form of creation of this asynchronous multimedia curriculum. And we believe once launched that the curriculum will offer an action to change practice moment, completing our first cycle as a learning health system project. And of course, by continuously evaluating the implementation of this course in phase 2, and perhaps expanding into new subject content modules in phase 3, we will engage again in the LHS cycle and more evaluating and more data collection, which we believe will lend itself to ongoing learning approach grounded in continuous improvement. So in summary, we believe this asynchronous course in TIC is a great example of a learning health system approach that is patient-forward, research-driven, and that uses a collaborative cutting-edge learning and evaluative approach built in from its inception. The project has incredible leadership by Dr. Dana Ross and Dr. Nancy McCallum, and has an amazing research team that includes all the folks listed on this slide. And a big shout out to everyone there. So I'm happy to take any questions that people may have.
Thank you so much, Sue. Yes, we welcome questions either in the chat or feel free to raise your hand.
Hi, Samia. Maybe I could just ask a question.
Sure.
I was wondering, Sue, what's the biggest challenge you find in educating people about trauma-informed care? where it could then be, because already people feel so overwhelmed in what they're doing in the individual patients, but so how do you think the program will, like, what's the most challenging part to get people to incorporate that into the regular patient care?
Well, thanks for that talk, Rylan, or that question, Rylan. I guess what I would say from the experience we've had so far in the trauma therapy program, where we've been asked actually to go to different departments in the hospital and talk about trauma-informed care, that actually staff, clinicians in particular, are very hungry for this kind of information, because if they actually know about it, it helps people be able to work with the kinds of situations that inevitably come up. So somebody who gets triggered or has some kind of flashback, for example, in a treatment area, can be really soothing and helpful for healthcare staff to feel like they have these skills in their tool belt. In terms, the other thing I think that's helpful is to see that even when people wanted, even when people had some trauma-informed care training in the past, and people did have some, people were wanting more. And so I think that staff in general are feeling that they have an appetite for more learning in this area, which I hope will help them support their patients.
Yeah, so maybe I can add to that in these sessions, so we got asked to go around and talk to a lot of different departments, like allied health and different departments during the pandemic, when people were seeing a lot of activation from patients, and by the sort of the triggers that were happening in the world and in the healthcare system. And we were really looking at activation of people's past trauma. And one of the things that the staff talked a lot about is how dysregulating it is for the staff themselves.
Mm-hmm.
And so kind of the knowledge and skills that will go into this course are partly about helping us regulate ourselves when kind of the contagion of the activation of other people's nervous systems takes over. And so that we can kind of, it's, a little bit like in medicine when we say, the first thing you do in a code is check your own pulse. That a lot of the skills will be not just things that you can help patients do, but also things we can do for ourselves in those really intense moments where that trauma history is activated and alive in the room.
Thanks, Nancy. That's super helpful.
Great discussion. We have time for one more question. No? Otherwise, please feel free to type things in the chat. If we have time at the very end of this session, we'll definitely get to those. So why don't we move on to our next presentation? Thank you so much, Sue. That was very interesting. Our next presentation is a duo. So we have Chandra Farrer and Jackie Follis. And Chandra, as many of you know, is the quality manager here at Women's. She's been a physiotherapist for over 20 years and completed a master's in quality improvement and patient safety at U of T. She holds a clinical lecturer status in the Department of Physical Therapy, and she's also a facilitator and consultant in the Center for Quality Improvement and Patient Safety, also known as CQIPS, at U of T. And so her QI projects include the evaluation of rheumatology models of care, referral management, electronic medical record utilization and optimization, and improving communication for patient safety. Jacqueline, or Jackie Follis, is an advanced practice nurse working in professional practice here at Women's. She's also the nurse lead for Choosing Wisely Canada, and she holds an adjunct lecturer position with the L. Bloomberg Faculty of Nursing at U of T. She's completed a fellowship in CQIPS as well here in Toronto, and is an advanced practice clinical fellowship, and also completed an advanced practice clinical fellowship from the RNAO on system transitions for young adults. And so here at Women's, Jackie's the lead of the Best Practice Spotlight organization, also known as BPSO, many of you have probably heard of. And she's leveraging her role in professional practice to identify and implement system solutions that improve patient care and ensure clinicians can provide the safest care possible. So please join me in welcoming Chandra and Jackie, who will be speaking on revolutionizing the best practice guideline or BPG program here at Women's.
Thanks so much for having us. I'm Chandra, and I can't see Jackie, but
I'm Jackie. I'm here up the top.
So I just wanted to start initially just with some quick acknowledgements. We'd like to acknowledge Jennifer Price and Jack Woodman for their support and direction on the project, and also to the participants in year 1 and year 2 for being part of this learning journey together. And so we'll just move into the background and context. So healthcare organizational culture is complex, but it's frequently cited as integral to success or failure of initiatives. And one aspect within that culture is a shared way of thinking, which can evolve over time. So we'd like to share this work with the acknowledgement that it's also in evolution. In 2021-2022, Women's College formally joined CEQIPS, which you heard in the introduction, which is a partnership consisting of U of T's Temerity Faculty of Medicine and 3 major teaching hospitals. And CEQIPS has a strong mandate to build QI capacity, energize research and scholarship activities to support health system needs. And to date at Women's, more than a dozen people have participated in formal training through CEQIPS. The objectives of our partnership with CEQIPS is to advance QI priorities at Women's, build QI capacity, and support QI as a building block for the learning health system. But Women's, like many organizations, faces challenges, including its ambulatory context, as well as limited dedicated roles and infrastructure.
Next slide, please. In 2015, Women's College Hospital received an internationally recognized designation as the Best Practice Spotlight Organization from the Registered Nurses Association of Ontario. Mouthful. This program is focused on moving research evidence to implementation through their best practice guidelines. They're called BPGs, and they use the Knowledge to Action framework. The initial years of the BPSO work at Women's College Hospital involved the corporate nurse executive directing the implementation of specific BPGs. In 2021, I started as the new BPSO lead and undertook a grassroots approach to change, revolutionize, we like to say, how we ran the program at Women's. Using information obtained through a professional practice needs assessment and the staff engagement survey, we conducted a gap analysis. Challenges identified were included low staff engagement, lack of focus on meeting BPSO deliverables, and we were in an accreditation year. To address these challenges, Chandra and I developed the BPG QI capacity building program for nurses, health disciplines, and staff. The program is monthly didactic QI training to apply to a project with coaching throughout. Our program intentionally leveraged existing structures within professional practice and quality to reallocate resources to support the work of BPSO and the CEQIPS partnership. Further, we collaborated with managers, directors to identify projects and staff to ensure that the work was embedded within the clinical operations and balancing with existing workloads. Our engagement with decision support, IMIT, and the AppQuit process allowed for access to data. We aligned the project to the strategic plan with consideration of the 4 pillars and the quintuple aim framework at Women's. Currently, this work is supporting the first 2 pillars of wellness and resilience and intersection of research, care, innovation, and education through foundational support of the LHS. This is evidenced by we're reporting metrics to the Women's College Hospital Wellness and Organization Resilience Committee plan, and our 5-year plan involves incorporating the remaining 2 pillars. The BPG QI capacity building program is modeling application of QI methodology as the evaluation is embedded inside a formal QI fellowship. Thus, we are role modeling QI work within this initiative to build a culture of QI at Women's.
So in terms of the methodology, we took a quality improvement methodology, and that was undertaken after reflection on understanding the problem by considering those background and contextual factors and building on some of the existing building blocks we had in place at Women's. Our goal, utilizing the model for improvement, was to increase quality improvement capacity building in nurses and health disciplines by 50% by April 2027. Our family of measures included the percentage of nurses and health disciplines who hold a best practice guideline certificate, champion certification through the RNAO, and also the number who enrolled into the program. Additionally, we're tracking the academic output and projects. The changes that were involved with the initiative involved increasing organizational support with things such as decision support, ensuring that alignment between program and department priorities, and ensuring dedicated time for the project work and attendance at the didactic lecture sessions. The professional development, including starting all participants with that BPG certification, and that really provides the foundational knowledge to implement evidence into practice. Then the delivery of the QI curriculum followed, but that was coupled with a project and coaching throughout. And finally, support for academic output through assistance in developing posters, presentations, papers. So the program is in its second year, or its second large PDSA cycle of implementation.
So some of our results, we started this project with 9 BPG champions in 2021. Today we have 106. Over the 2 years, we have had 53 staff enrolled, which represents about 17% of nursing and health discipline staff having participated or are participating in our BPGQI champion training, BPGQI training program. Staff are attending sessions, leading projects, and contributing to scholarly output amidst their busy clinical schedules.
The project completion rate for our year 1 was 63%. The goal with each year or cohort is really to develop that QI leadership within our organizational talent and build a community of practice. And so to date, we have 6 mentors from year 1 who are mentoring year 2 trainees. To support staff development, participants have the opportunity to pursue additional training through our CQUIPS partnership or other formal QI training if they are so interested. And through academic output and ongoing professional development, as well as building QI leadership, we're working towards spread and sustainability. Next slide.
Thank you. Some more information about this. The initiative has 30 projects utilizing 8 best practice guidelines across 26 programs or departments. The asterisk on the slide denotes programs with enrollments in both years. So we've had some continuation through programs. The breadth of the staff engagement includes 18 RNs or RPNs, 5 nurse practitioners, 3 advanced practice nurses, 16 health disciplines. We've had 2 managers participating, 3 support staff, and 8 quality and safety board leads, consisting of various administrative staff, a truly interprofessional representation. The initiative recognizes the need for organizational support from decision support, clinical applications, managers and directors to achieve goals through collaborative relationships. The 8 best practice guidelines support organizational work to improve patient outcomes, patient safety, and interprofessional practice. An additional bonus includes the formation of cross-clinic teams to support further knowledge exchange across the organization, thus working to break down internal silos.
So how does this work align to the learning health system pillar? This work fosters a culture and enhances competencies of rapid learning and improvement, which are 2 characteristics of an LHS identified in the literature. And within the LHS cycle on the diagram, the gap analysis performed involved that collection and analysis of data, which is the data to knowledge flow aspect within that diagram. And through utilization of best practice guidelines and evidence embedded within each of those smaller projects within this larger project, this work really supports that knowledge to practice flow. And the participants are using the knowledge to action framework from the RNAO to implement. The grassroots approach fostered collaboration between frontline staff and leadership at various levels, and this allows for peer involvement and employee ownership of quality work. And this is particularly significant given the lingering impact of COVID-19 on our workforce. We do continue to monitor data evaluating the project, but some of our learnings to date include the sustainability of the previous year's projects is critical while balancing participant choice. Coaching is essential. Building mentors to support the next year embeds knowledge across the organization and develops local leadership within departments and programs. Health and human resource challenges continue to impact the project completion rate, although we're very proud of our project completion rate. And really grounding the work in alignment with strategic priorities is essential, both at an organizational level, but also within the programs and departments. And also modeling that QI methodology by evaluating this larger project really provides credibility and models best practice. So overall, we're intersecting the program to meet organizational priorities, use evidence-informed patient needs to inform the work, and consideration for healthcare workforce desires.
So our next steps. They're going to involve strengthening patient engagement with a plan to have patients co-facilitate a session on patient engagement. We hope that get them to provide guidance on our future BPG selection and for input on applicable projects. We want to ensure equity for both staff participation as well as embedding an equity lens within projects.
And using the BPGQI training program, we hope to identify future CEQIPS participants to further build upon our CEQIPS partnership and build internal QI leaders. And finally, we need to explore opportunities to build that QI operational infrastructure at program levels to ensure continuity of the work. For example, quality committees across different programs could leverage the skills of those who've acquired the training to lead future work. And with that, we'll take questions.
Thank you so much, Chandra and Jackie. That was really fascinating and very relatable, you know, as we kind of move towards a learning health system at an organization level, thinking about everything that you've considered, we're considering, you know, how do we build a culture of not just curiosity, but building that capacity for different methodologies, collaboration. You have the whole interprofessional aspect to this, and also finding champions. So thanks very much for sharing. We're going to open it up to questions. I do see a hand up. O'Neill, please go ahead.
Hi, Jackie and Chandra. Thank you for that. It's very exciting and interesting work. I'm curious if we think of mapping out like who's interested in this topic, who has the ability to work on these, you know, QI questions, who, you know, or let's take it as proportions who have some interest, proportions who have some capacity, proportions who have some time, proportions who get bogged down because they don't have that operational infrastructure, just too much work. Like I would love to do this. If it was half the work, I would do it. But at this point, you know, I don't. And so what does that drop off look like? And, you know, it looks like you've targeted a couple steps along that way. And obviously executing on a project is a, you know, another barrier. But I'm curious, where does, as an investment, operational infrastructure, how important is that versus people just being interested and, you know, generating interest or building capacity?
I'll start. Chandra, you can jump in to cover what I haven't addressed. The operational infrastructure is really key. You can't, it's sort of like chicken and egg, which comes first. But ensuring that we identified people who were interested in doing this work, and then we aligned. We did a lot of background work that's not addressed in this presentation on ensuring that if there was an individual who wanted to participate, their manager was on board, their manager and director was on board. What kind of project were they interested in doing? We aligned it to the guidelines that we are, like, I have to report back to the RNAO which guidelines we're doing. There are reportables. So we tried to align their project to one of the guidelines that we already were invested in. And then ensuring that they were able to get to the sessions. So we actually made a modification from year 1 to year 2. The lunchtime is when we did it year one, because we knew that that was a likely time that most people could get to the session. Year two, we bundled 4 hours together so that the first initial session was 4 hours long, and they got more of the content to get going on it. So if they missed sessions later, which definitely happened, they had enough information. So the operational piece was really important, but then also finding the people that were interested. We did a lot of walking around, talking to teams, talking at huddles, using our knowledge of the different clinics, and trying to pull people forward if they indicated an interest. Chandra, did I?
Yeah, and I'll just, I guess, because I'm a data geek. So we have 106 BPG champions. In terms of FTE equivalents, we have 47 who have participated in the QI training. So if we, it's roughly 50% who then carry forward. And then we have a project completion rate of around 63%. So there is a drop off. And one of the major contributors to the drop off, which you've identified, is the operational support. So the things that we're observing is that when the projects are embedded within the priorities of the program or the department, they are far more likely to be successful. And then having mentorship and coaching throughout to really overcome potential barriers is really key for moving the projects forward. And so the most important part, I think, of the projects of the program is the project work that people are doing and that learning. And then the other thing I'll say is the thing that I observe, and I've not measured this, but that community of practice and feeling like you have connections across the organization and networks, whether that's within the group or people that you meet through your project work, I think is really, powerful for the work to date.
And sorry, last point to that, the community of practice piece, we were fortunate in that we were able to do this in person. So last year, I don't know if everybody remembers, but at the very beginning of September 2021 or 2022, we were still not allowed to completely meet in person. So we used the auditorium. We ensured we were meeting the IPAC protocols, and we kept people 2 meters apart, a moose distance apart, in the auditorium and masked, so that we did not get thrown off with any COVID-19 impediments. But I think the in-person piece really led to some of the built the excitement to the program. When we had year two, we weren't clear if we would have the same interest, and we thought we'll cap it at 20. We have over 20 people who are interested in participating. So we were able to maintain the same interest.
Thanks so much. I apologize. I do see more hands, but we do need to move on in the interest of time. Please feel free to share your questions in the chat, or you can, of course, email the speakers later. Great. So we're moving on to our third and final presentation, and this is by Dr. Arun Prasad, who's an assistant professor in the Department of Anesthesia here at U of T. He obtained his anesthesia training in the UK and completed a fellowship in regional anesthesia at Toronto Western Hospital. He is currently the resident curriculum coordinator for the anesthesia residency program at U of T, and he's also leading the leading fast-track surgeon in gynecologic and general surgery here at Women's. So welcome, Dr. Prasad.
Hi, Samia. Thanks for having me here. Nice to be here, and thanks for the invite to be part of this exciting team that's presenting this seminar series. So my talk here is going to be on pushing boundaries in ambulatory anesthesia. And Women's College Hospital, as we all know, is an ambulatory center. The surgeries that we do here are all-day surgeries, and we try to increase the capacity and the scope of these operations, and to include the majority of patients who would otherwise not be eligible for a day surgery. We still try to make it possible at Women's College Hospital. As you know, from a surgical standpoint, anesthesia plays a very important role, and it is a big teamwork in terms of making sure the patients have a smooth transition from the preoperative to the postoperative phase of care. When it comes to ambulatory surgery, most of all, as we know, all our patients go home the same day. So we have been achieving those goals, and we were wondering what we can do better. Certainly, there were patients who were not initially selected for surgery. So we were thinking of which patients can be further included in this program so they can be benefited from an ambulatory care, so that they recover at home in the comfort of their home. And more patients get done through an ambulatory setup. Likewise, for surgeons, they have operating privileges at Women's College Hospital, and it makes them easier for them to operate these patients at Women's College. So we had to find ways how we can fit these patients who may be potentially not suitable for a day surgery, but still be possible to be done at Women's College through a certain modification of the pathways. For the health system itself, there are a lot of patients who are on waiting list, waiting for surgeries, and obviously due to lack of beds, they get postponed, they get canceled. So having surgery done on an ambulatory basis is certainly a bonus from the health system point of view in terms of cutting down the wait lists and moving the surgeries faster. So the two procedures that are commonly done at Women's College are, one is an inguinal hernia repair for the general surgery, and then the other one is a hysteroscopic surgery in the gynae surgery department. I have to thank Dr. Urbach from the surgery, general surgery, who is a critical partner in this initiative in terms of developing the local anesthesia protocol for the inguinal hernia repair. From the gynecology side, Dr. Solnick, Dr. Murji were helpful in terms of creating this pathway in devising a care so they can be operated under local anesthesia and sedation. From the anesthetic standpoint, I have to thank Dr. Riazi and Dr. Kirkham from the leadership side in order to help us facilitate and bring resources together to get this plan sorted out and initiated. And obviously, the nursing team and the managing team in the perioperative services have been extremely helpful, receptive to ideas, open with feedback, and able to work with us as a team to get this all accomplished. Next slide, please. So the two procedures, I just like to highlight what we're doing here. One is the inguinal hernia repair, which is essentially inguinal hernia that is not an urgent operation. Patients have the hernia, they wait for months or weeks or months together before they end up seeing a surgeon, and then they wait a few more weeks or months before they get a surgical date for its operation. It's a fairly simple procedure, but if it is not operated on a timely basis, there is a potential for the hernia to get obstructed or strangulated, making it an emergency, potentially converting something that can be done on a day surgery, quick, simple basis to an inpatient surgery with needing hospitalization and further escalation of healthcare needs. So essentially, this is a small incision that is done in the inguinal region, and the surgeon goes in, reduces the hernial sac, and then the abdominal wall is resutured either by itself or using a mesh to cover up the defect. Typically, inguinal hernia repair takes anywhere from half an hour to 1 hour kind of operation, depending on the complexity. Hysteroscopic surgery is a very common approach used by gynecologists in order to deal with the pathologies within the uterus. So that this involves passing a hysteroscope, which has a camera and a cautery device or a snare, which is attached at the tip, and it can be used to treat pathology, intrauterine pathologies like polyps or adhesions or septal that needs a dissection, biopsies, diagnostics, so multiple uses for this procedure. Again, it's a very simple procedure. It's done half an hour to 45 minutes. Typically, both these procedures were done under a general anesthetic. So the challenge with having these being done under general anesthesia is it involves much more time for induction and for extubation. It involves more airway intervention. So essentially they'll end up having respiratory tube like an LMA or an endotracheal tube. So high risk of respiratory complications, greater than anesthetic needs, so more nausea and vomiting. And overall, it makes a small surgery a little more complex big procedure because of the general anesthesia in itself. So we looked at the surgical techniques, and although it's not new, these procedures are done sometimes with local anesthetic and sedation. So we wanted to expand the scope of applying this local anesthesia and sedation for these two procedures at a wider scale. And which place is better than Women's College Hospital to try this? So we sat down together and we looked at how we can improve this in terms of coming up with a protocol. So next slide, please. So we developed the so-called fast track model where we invested time and effort at all three phases of the patient care, preoperatively, intraoperatively, and postoperatively, in order to make this as smooth and as efficient as possible. So at the preoperative phase, the surgeons identify these patients who are suitable to be done under local anesthesia and sedation, in the sense the hernia should not be too big. It should be suitable to be done within like a short span of time. And from a gynecological perspective, it's not a procedure that is bloody, or it's not something that needs a general anesthetic in terms of the size of the polyp or the myoma or whatever. So surgeons selected the suitable patients and were referred to anesthesia, and we did a preoperative anesthetic assessment in order to optimize these patients if they have any comorbidities that may preclude them being done under local anesthetic. Or if there are issues, then we optimize them, like controlling their blood pressure or diabetes, or if there's anemia, giving them preoperative iron therapy, so that on the day of the surgery, they are well optimized and they don't need a post-operative admission. So this was our first stage. And then next thing was we made sure we ordered them preemptive analgesia. So patients wake up with sufficient pain relief after the operation. Intraoperatively, the main changes were local anesthetic infiltration by surgeon. Again, we devised a specific local anesthetic mixture, in the sense that will work fast for the intraoperative phase, and also will work for the postoperative phase in order they have good postoperative pain control. So the local anesthetic infiltration was done by the surgeon, and we used special pumps that are called TCI pumps, which is called target controlled infusion pumps. And these pumps are excellent in terms of providing a very good anesthetic plane, and patients tolerate the procedure extremely well. And these pumps are able to also give us an indication when the patient will wake up when we stop the sedation. So the surgeons would give us an indication like, I have 5 minutes left for surgery or to finish, and then we stop the pump accordingly, so that the patients will wake up in the OR at the end of the surgery with less grogginess and able to really be fully awake at the end. And they are so good that they can transfer themselves from the operating table to the wheelchair or the stretcher. So that takes them to a faster recovery pathway. So in the postoperative phase, they go direct to phase 2 recovery, which reduces the time in the recovery area. They all get preemptive antiemetics, so they have less nausea and vomiting. And obviously the pain control was addressed with intraoperative opioids, which is like short-acting opioids, and the local anesthetic infiltration. So intervention at all three phases were modified and selected so that we can have these patients done on a fast track basis. Next slide, please. So this is trends that we have now. So I just want to draw your attention for the hernia repairs that we did, comparing the year 2021 to the data that I have for the last quarter of 23-24. So you can see the number of local anesthetic surgeries have obviously increased, almost doubled, and we've cut down in terms of the general anesthesia almost to none towards the end of 2023. So that is the trend that we are seeing, and likewise we have similar trends in hysteroscopy. Next slide, please. So here as well, you can see the general anesthetic surgery, general anesthesia for hysteroscopy have decreased significantly, and we are doing more and more under local anesthesia and sedation. So the various other documentations are, this is actually a data extracted from EPIC. So depending on how they documented either as local with sedation or local anesthetic on its own, you may see some differences. But the trend that we have to watch out for is the reduction in the use of general anesthesia for these patients. Next slide, please. So how we are integrating this in our learning health system model. If you look at on the right side of the knowledge to practice flow, that's our current to the recent past intervention, where we developed the perioperative care to bring this fast track model into practice. And currently we are in the phase of like taking action and changing practice and collection of data, so which is the fast track model implementation and collecting data. So I'm expecting further data collection during the course of this year and possibly towards the end of 2024, where we will be having more robust feedback and data as to how these patients have done so far, and how we have managed to increase the numbers and what the patient satisfaction is. So a future study is in the pipeline in order to look into and analyzing this data. Next slide, please. So the future directions for this, we're going to revisit this group, as I said, in order to measure the satisfaction, readmission rates, and complication rates. Although at the moment, we don't know any readmission rates for these patients. Not many complication rates either in terms of any intraoperative events or immediate post-operative events. There has been one or two where the local anesthetics have given a little bit of a femoral nerve blockade, but then we had to wait for a little bit in the recovery for the block to wear off, and patients were still discharged on the same day. The other things that in the scope of this intervention would be looking at other surgical procedures which can benefit from such intervention, like knee surgeries. And we are always looking forward to collaborating and sharing care pathways between departments to make our patient care efficient, and obviously to continue teaching and learning with knowledge transmission. Next slide, please. Yeah, that concludes the my topic here, and I'm happy to answer any questions.
Great. Thank you so much, Dr. Prasad. Fortunately, we are at time, so I'm wondering if maybe folks can forward their questions through email, but thank you so much. We do have to move on. We have another meeting with the presenters, and just want to thank everyone, all four of our presenters. They were very interesting projects, and we'd love to hear your feedback too about this session. I mean, it was unique compared to our other seminars, and we would love to hold more seminars like this in the future, featuring folks from women. So thanks very much, everyone, and take care.